hypertension from just a general, and then there'll be another type. I don't want to say another type, but a lot of patients with just long-term pulmonary hypertension are treated as outpatients. So it's a horrible disease. And the other pulmonary hypertension that you guys are going to be treating are patients in your ICU that have pulmonary hypertension, are severely hypoxemic, have cardiac problems, things like that. And then of course the other one you see then is babies. Did you guys talk about persistent pulmonary hypertension of the newborn? You will. You will. So a lot of hospitals, so for the longest time, nitric oxide was the only thing that we knew that caused pulmonary vasodilation. And so for babies, in particular, nitric oxide was the treatment of choice, and you'll learn that with Ms. Profit. But they're now also using Flolan with them. Flolan is way less expensive, but some babies are actually getting both. So they get Flolan and nitric oxide, and you'll see that when you go on your NICU rotations next term. So, but pulmonary hypertension to begin with is, there is pulmonary arterial hypertension, and then there's pulmonary hypertension. A lot of people just say pulmonary hypertension in general. So, and you can see here, if you see our normal healthy artery there, where everything looks nice and happy, then you see how it changes with mild, moderate, and severe. So we've got thickening there, fine fibrosis, so that's mild. Moderate, you can see how much more it's closed. Where severe, you've got lesions, and it's just severe pulmonary hypertension is terrible. So, but you'll see the progression, you're just gonna get more scarring, more scar tissue, more narrowing of the pulmonary arteries. What's that gonna do to your heart?
Make it work harder.
Extreme strain, right? On which side?
Left.
Right. Pulmonary system, you guys. Blood is going to the pulmonary system from the right side of the heart. So these are patients who get, what's right side of heart failure called?
Cor pulmonale.
Cor pulmonale. So these are patients who get cor pulmonale from pulmonary hypertension. So there's a number of reasons that people get it, and so there's some different categories, and that's what's on this page that says, what's your pH? So, and we're also gonna see here, which one is the most common out of all of them. So you'll see this first one, group 1, is only about 3% of patients, and that's good because it's bad. So this can be, you know how people can get idiopathic pulmonary fibrosis where they just get it for no known reason? This is the same way. So patients get pulmonary hypertension for no known reason. How terrible could that be? It's just all this excess work on the heart, and that eventually is going to lead to heart failure and death, because eventually the heart just can't pump anymore.
And that's the group 1 you said?
That's group 1, yes. So that's, the general concept is just you get this narrowing and thickening of the pulmonary arteries. So it's either unknown, sometimes it can be genetic, and that's why I just tried to keep it simple, because if you look at some of the charts on all the different types of pulmonary hypertension, you're gonna see this many things. So group 1 is associated with, and that's technically the one that's called pulmonary arterial hypertension. It can be due to drugs, genetics, for no known reason. It's also kind of like pulmonary fibrosis is linked to some autoimmune diseases, so is pulmonary hypertension. So these are people that are going to be treated, and we'll talk about when we get to the treatments, on some medications. There's no cure, there's no treatment for it. So the only thing we can do is try to relieve the patient's symptoms, and for patients that have it due to other reasons, we can also look at lung transplants. So, do you guys have any questions on that first group? Okay. The second group is people that get pulmonary hypertension because they have left-sided So they have CHF. The left side of the heart has to be overburdened and working, and so eventually it starts to fail, as we know. So it can't pump blood efficiently. So eventually that blood will back up to the right side, and then the right side has to work harder because it's trying to overcome the work of the left side of the heart, and then it also fails. So those patients have left-sided heart failure and right-sided heart failure. Bad combination. So, and that is the biggest group of patients. 68% of people that have pulmonary hypertension have it because they have left-sided heart disease. So it's age, they have had heart attacks, whatever the case might be. And the only thing you can do for these patients is try to treat the underlying problem. So try to work on fixing the left side of the heart so the right side of the heart doesn't have to do so much work to overcome it. Like if your left side is paralyzed, your right side has to do all this other work to overcome. So it's kind of like that. Make sense? Okay. Type 3 is for patients that have chronic lung disease. And this is going to be especially like your pulmonary fibrosis patient, your COPD patient, cystic fibrosis patient. The underlying root cause of this is hypoxemia. So hypoxemia, and I like this little picture here, because what happens is, well, number one, what does our body make more of in response to chronic hypoxemia?
Red blood cells.
Red blood cells. So they get polycythemia and they have thicker blood, right? Yeah. The other thing they do is the lungs and the capillaries, they shunt blood away. So if you have areas that are not getting enough oxygen, so let's say pulmonary fibrosis, we have all that scar tissue and the alveoli either not opening at all because they have atelectasis, or they're just so poor at gas exchange because of the fibrosis. So you have this area here that doesn't have oxygen. So the body actually sends blood away from that area. And when they do that, they vasoconstrict. So they vasoconstrict to keep the blood to go a different area. And so that makes the pulmonary hypertension worse as well. And all of that causes excess work on the right side of the heart. So the ultimate thing that helps here is to treat the underlying cause, but the number one thing that helps the type group 3 is oxygen. Because if you can correct the hypoxemia, you will prevent this damage from happening. A lot of those patients, we all know those are long-term chronic fatal diseases. So a lot of those patients, eventually that's going to happen anyways, but if we can slow down the progression, then our patient can have that better quality of life. Okay? Group 4 is actually done in a patient who has chronic and large amounts of blood clots. And the blood clots block off the blood flow from getting to certain areas. And that is what causes the hypertension in those patients. So they can try to remove clots. There's also some drugs that they use, but some people are just more prone to blood clots and have large amounts, but it's a very small population of patients. And the last one is everybody else. That's kind of where everybody else falls into. Anyone else who has pulmonary hypertension, but not one of these reasons, they fall into that one. So in the ICU, like I said, we'll see ICU, ARDS patients. They've got vasoconstriction and pulmonary hypertension. So normal pulmonary hypertension is 25/8 with a mean of, I'll have to look it up, but when you have patients with pulmonary hypertension, their mean is greater than 25. So you might see, if they have a pulmonary artery catheter in, this would be one patient, which we'll talk about hemodynamics in a couple weeks, where we might see this at 40/20. So it's like an elevated systemic hypertension. This blood pressure, which is the blood pressure in the lungs, is very high in these patients, which makes their mean go up. So that's what we're talking about. So if we put a pulmonary artery catheter in and we're measuring pulmonary pressures in our patient all the time, which we would be in this situation, then you'll be able to see their pulmonary artery pressure on the monitor. And so this is normal, and you will see it very elevated in these patients. So the reason we're going to give them things like Flowland is to try to bring that down because of all the work it causes on the right side of the heart. So we see it with ARDS, we see it with cardiac patients, like an MI, cabbage, post-op, situations like that. In the NICU, like I said, it's PPHN, persistent pulmonary hypertension of the newborn. Okay. So you can go over to treatments once you get your notes on that. And I'm just going to focus on a couple of these and more. As I said, there's no cure for pulmonary hypertension. So as I said already, patients that have hypoxemia, we need to give them oxygen. You'll see kind of the normal ones, diuretics, if our patient has too much fluid, like in CHF, Coumadin for thinning and preventing clotting, and digoxin is a inotropic agent, right? Remember we talked about that? So it's going to help with the pumping of the heart. So you don't have to know all these names here, but you need to know the endothelin receptor antagonists and phosphodiesterase inhibitors. Just know those categories. So the ERAs are going to prevent the constriction. And the phosphodiesterase, they actually secrete more of the natural substances in our body that allow the narrowing of the arteries. Yes?
The last part?
For the phosphodiesterase?
Yes.
They actually produce the substance found in our bodies. They produce natural substances that allow for vasodilation. And then, so that would just be medicine people would be on at home. So for people not in the ICU, Flowland is given by IV at home. So they'll come in and learn how to use it, and then they use it at home. Same, and the other word I want you to know is prostacyclins, because anytime you hear prostacyclin in anything, they're talking about the name of a drug, that's going to be a treatment for pulmonary hypertension. So they could say inhaled prostacyclins. These inhaled or IV help relieve the constriction and promote vasodilation in our patient. But like some of these, I mean, again, we're not going to get into the details of these, but like this iloprost, they have to take it up to like 9 times a day because it only lasts like 2 hours. So it might be the patients can start on these. As the pulmonary hypertension gets worse, they have to add other therapies in. David?
So for Flowland, what is going to be like the decision that you choose to give an IV push or give it through an inhaled method?
IV is at home.
Okay.
Inhaled is in the ICU.
Okay.
It's FDA approved for IV use. But we've learned over the years that we can give Flowland through aerosol, and it's actually found to be more effective than nitric oxide. So when our patient's on a vent, we're gonna give it directly so it goes right into the lungs. Kind of like that target, like the same reason we would do an aerosol, it's like instant to the area we want it to go in.
Okay.
So besides for Anna, how many people have seen Flowland used? Fair, some of you? Yeah. Yeah. You're definitely going to be seeing it out there. Daniel, you're going to be seeing it if you stay awake. So in a couple weeks, I'll show you, I'm working on getting, the only thing I don't have is the infusion pump. I have the aerogens and all of that. So we'll look at how to set it together. And then I can just show you a video about how it connects with the infusion pump. So the other treatments are mostly like research clinical trials and things like that. So that's what we're looking at. So these patients are going to be on vents, and we're going to run the Flowland through the vent circuit and give it to them in the ICU. And you could see them on Flowland and nitric oxide together, or one or the other. Because nitric oxide does work, so, but again, that's going to be the ICU through a ventilator. But the nitric oxide is crazy expensive. It's unbelievable. So there are any questions on that? Yep.
On the board, pH mean is greater than
25.
25.
Yep. So the problem with, one of the biggest problems with pulmonary hypertension is diagnosing it. If your patient has COPD or left-sided heart failure, it's easier to discover in those patients because we know that they've had hypoxemia, they've got left-sided heart failure, now they're going to be getting right-sided heart failure, JBD, and all of that. But to the otherwise healthy patient who is just now having some shortness of breath, they can't walk, maybe they're having palpitations, things like that, it's such general signs and symptoms, it's hard to figure out what would be the root cause. So you imagine you have a patient who comes in to be seen, or even into the ER, and they're like, well, I'm getting short of breath, and I can't walk up the stairs, and I'm having palpitations. Okay, well, that could be a billion things. So they always start out with just some regular tests, and that's just kind of what this talks about here. The blood test, try to figure out, these are people who are probably going to have a gamut of tests to try to figure out what's wrong. Chest x-ray, they might see it on a ECG because it would say right ventricular hypertrophy, depending on the stage. So right ventricular thickening of the wall. An echo, they would definitely see the reduction in function on the right side of the heart. PFTs, depending if it's hypoxemia that's causing it. 6-minute walk test, because these patients are typically going to become short of breath on exercise due to the extra work on their heart. But the main test that actually has to be done to actually confirm a diagnosis is the right heart catheterization. Because when they do that, they can actually measure the pressures inside the heart. And that's when they can determine that the pressures are excessively elevated. So at some point, the patient will be scheduled for a right heart catheterization, and that's where they'll find out that they have pulmonary hypertension.
Is that with the arteries into the heart?
What's that?
That's when you put the arteries into the heart.
Yep.
Measure all that.
And they're gonna put a catheter right inside the right side so they can measure the pressures.
Is that Swan-Ganz stuff, or is it different?
No, this is, you can measure the pressure in the ICU in a patient with the Swan-Ganz, but this would be done like as an outpatient. If your patient's in the ICU and you're monitoring them for pulmonary hypertension, then they're gonna have a Swan-Ganz catheter in. So this patient who we suspect pulmonary hypertension, they'll be scheduled for an outpatient right heart catheterization.
Okay, cath.
Jeremy, would you like to join us? Sit up, please. You guys who want to go to sleep, I can send you home. You won't get to take your midterm.
Oh, Jesus, no.
So, huh?
You should have told me I took the midterm.
So sit up and pay attention. So it's going to be done usually through the femoral artery and up in, or the femoral vein, and go up into the pulmonary system where they can measure the pressure and then give a definitive diagnosis. The vasodilator study, I'm not gonna worry about that for you guys. I just want you the gold star, so after we've ran all these tests and we need to confirm a diagnosis, they have to have a right heart catheterization to monitor the pressure. Okay? So, in a couple weeks after we get through the midterms and stuff, I'll show you the stuff that we use to hook up Slowland, and I'll show you the video